Hi, everyone. I'm Haidy Marzouk, part of the PPR committee for the AAOA. And today we're going to do a quick interview style session with an expert in pediatric otolaryngology, Nalin Patel, who practices out of Florida. And we thought we'd catch up with him regarding some of the common challenging questions we get from parents in our general practices for PEDS ENT. How are you, Dr. Patel?
Great. Thank you for having me, and hi, everybody, out to the AAOA.
So, when I'm in the office, sometimes I get questions that throw me a little bit for a loop, or even, outside of work from friends and family. So, I'm going to just kind of hit you with some, see what you think, pick your brain a little bit. So, one of the common ones I get with kids who have eustachian tube dysfunction, the parents will tell me, I see a chiropractor for a lot of my problems, and the chiropractor tells me that they can actually do an adjustment on my child and they can fix their eustachian tube dysfunction. And, sometimes I'm not sure how to respond to that. What are your thoughts?
Well, I do I do encounter this question with some frequencies, and my approach always is, first, I'm not an expert in chiropractic care, but I have read some information about it and the method in which it is supposed to help alleviate otitis media is if there is inflammation, some type of a lymph node causing muscle spasms or impaired lymphatic drainage. That's the primary mode in which spinal manipulation could theoretically help. And in I to date, I don't know of any negative studies. The main concerns I pass along to the parents is that most things out there should be used in conjunction with the current standard of care, and it should not result in delay of effective management. And delaying managing the child's otitis media can result in having to go on more antibiotics, which can have more adverse side effects, leading to antibiotic resistance, delay in speech, as well as the potential for C. diff, gastroenterocolitis, and those types of things. So it is something that I usually don't dissuade in the practice, but I do encourage the families to make sure that in seeking additional help for otitis media, that they can pursue all avenues, but not to delay surgical treatment if necessary.
So, judicious use of kind of an adjunctive technique is how you would place that kind of in the treatment algorithm.
Absolutely, absolutely. It is something that I don't think has significant downsides if it can be something that's initiated very quickly. If it's going to delay care for 4, 6 weeks, 12 weeks, then obviously there's some concerns with that.
Sure. Well, another question that I get along the lines of recurrent otitis media is, do we have to give antibiotics? A lot of parents I find are quite cautious nowadays with all the literature that they see on the internet about gut flora and selecting for resistant bugs. They really want to try to avoid antibiotics for their kids. And so, how do you kind of counsel patients? Because a lot of pediatricians want to give antibiotics for every ear infection. So, what is your kind of go-to way to counsel parents on? Does it have to be every infections? What's a signal that an infection might warrant antibiotics and things like that?
Sure. Now, depending on the age of presentation, in the first few years of life, most otitis media are suspected to be actually viral in origin, at least for the first 24 to 48 hours. And so, depending on symptoms, antibiotics have been shown to improve resolution of pain, as well as address the specific bacterial component. But if you have a viral otitis media, it's not going to help in any way. So, but the use of antibiotics does prevent complications associated with bacterial otitis media, such as tympanic membrane perforation, mastocytitis, as well as bacteremia. I do encourage parents to use antibiotics if you have significant systemic symptoms like febrile symptoms, as well as fatigue, and those types of things. Or if you see an impending perforation, then I do think that antibiotics are strongly indicated or warranted. Otherwise, I guide them as to, here's, if you have a prescription, these are the reasons why you should start antibiotics. And there are, in the absence of symptoms and just an ear that looks infected, but the child's pretty happy and playing, there is not a strong indication that you have to start antibiotics right away.
So do you write wait and see prescriptions in the office?
Yes, I do, with
Okay.
instructions on what symptoms to watch for, or to call back if you have questions at that point. And if you're not
Sure.
sure, call back and we'll guide you.
So, in your experience, because I write wait and see prescriptions too,
Mhm.
do you think that the parents lean towards giving the antibiotics, or they're actually pretty judicious in terms of the use of antibiotics?
Well, when they're asking the questions, does my child have to start the antibiotics? I would
Yeah.
automatically, filter out the parents who want to just start antibiotics right away. So
Sure.
I do think that they try and hold out, but I do encourage them. If you start to notice these symptoms, and in general, I always tell them, look, if you're questioning if you should start the antibiotics, you probably should just start it.
Hmm. I actually find that parents are not trigger happy. Sometimes
Right.
I'll be the one to encourage the wait and see. I see something that might be on the cusp of, but like you said, the mood and the temperament, there's no fever yet, and they're not
Right.
really an extremis. And I actually find that parents are very judicious in terms of giving it or not. They're willing to wait the couple of days to hold out. And so the other question I have was there's some literature out there about short versus longer courses of antibiotics, 3 to 5 day courses
Mhm.
of other antibiotics that we traditionally give 10-day courses for. What are your thoughts on those sorts of options for kids?
Yeah, I mean, it would depend on the individual situation. If you have kids who are coming in, usually in my practice, kids have been on 6 or 7 rounds of antibiotics before
Yeah,
they're referred over. So just with that type of history, it would be challenging to say just do it for 24 hours or 72 hours, because they've already shown a pattern in which the antibiotics are not super
sure.
effective based on primary care management. And, if I'm seeing them early on, I do think that the first few otitis media definitely don't have to be managed with 10-day courses if the child has a competent immune system.
Sure. Along the vein of alternative treatments, like
Mhm.
we were talking about the chiropractor before, a lot of parents have been reading about salt rooms or herbal steam bath as a possible treatment for eustachian tube dysfunction or, ear infections. How do you counsel the patients or the parents who are coming in with that sort of literature and that they've seen on the internet about the efficacy?
And this would fall along the lines of adjuvant therapy. And I've actually done some reading on this to try and figure out, how could this help? Why are parents seeking these types of things? And, the history is that it was first identified after watching asthmatic patients in Eastern Europe descend into the salt caves. Those that were asthmatic, their asthma symptoms seemed to be better managed and better controlled. And so that information uh, has spread to where now it's being used now, in alternate treatment that we use in otolaryngology, such as in kids, newborns and infants who catch upper respiratory infections, who are having cough, reactive airways. We often do use saline nebulizers, and it helps them breathe more comfortably, able to fall asleep, and reduce the symptoms. We also use hypertonic saline to help with mucociliary clearance in patients who have chronic rhinosinusitis. So, it's not unheard of, even in conventional medicine, to use saline as adjuvant treatment for other allergic diseases. And so I don't think there's frequently reported adverse side effects in the use of salt room therapies. I can theoretically understand, with if it's been shown to help with symptom management, but again, not large, clinical trials and those types of studies, but to help with asthmatic patients, that I don't think it's going to be very harmful to try in patients, who have otitis media or sinusitis, to say, hey, just as long as it's not delaying care, as we talked about with the other treatments, it could be used in conjunction to say, if it's improving the child's symptoms as well as helping with medullary clearance of fluid and those types of symptoms, by all means, we'll work along with those specialists who are helping you with that.
Is that kind of, I guess, philosophical vein the same as you would counsel them for allergic rhinitis in terms of the salt rooms? Because I've seen it also advertised to help with
Right.
allergies in general.
Yeah, I mean, so
Um,
in my patients who come in with otitis media, the allergic marches, they start out with otitis media, then they have allergic rhinitis, they end up with allergic asthma as the years progress. And so I do think that in all these patients, I do get reasonably positive feedback in the families who've tried it. Now, in terms of, do I see them long term? Are they coming back in 3 years, 4 years, 5 years? Do the symptoms return
right,
when they stop salt room? I don't have that data, but
right.
in general, parents come back and they find that it is generally helpful in helping the kids feel better.
So more of like a symptomatic relief, but it's
Right.
obviously not going to cure them like immunotherapy, like
I
in the
don't
sense
think that
that
it's going to do that.
immunotherapy would
Yeah.
augment their immune system and whatnot.
Yeah, you're right. I do think that it could, in theory, help with mucociliary clearance, whether it's with asthma or the eustachian tube and the middle ear, as well as in, in the nasal passages. But, again, I don't see how anything like this can have lasting benefit beyond the time that you're using it.
And do parents ask you in general for more natural or alternative treatments for, children with rhinitis?
Well, they always ask for what are alternatives to surgery.
Mm-hmm.
And so, I talk about the things that are out there in terms of, these are the things to try. But the downside to trying the conservative thing is that you're prolonging the time into which, surgery in general is the most effective treatment based on the data. But obviously, surgery is never going to be 100% effective. And so, I do see kids who've tried surgery and it hasn't been effective. And at that point, if already have had a competent provider do an effective, an indicated surgery, and these kids are still having otitis media, you really can't continue to do the same thing over again, thinking you can do it better. You want to try other
Sure,
things. So, hey, try this and see if it's helpful as adjuvant treatment in the hopes that, you can get to the allergy piece better.
sure. Well, I mean, a lot of parents, when the kids have allergic rhinitis, that might not be surgical, that, especially when there are cultural differences in terms of the way different parts of the world treat rhinitis, they'll come to me with kind of like lists of different herbal remedies
Mhm.
or things like that that they've seen in terms of seeking a more natural way to treat allergic rhinitis.
Mhm.
And in fact, in the Explorers course coming up, we will have some information about, alternative medicine for allergic rhinitis. What is your general philosophy when counseling parents about um, alternative remedies such as herbal remedies or acupuncture or stuff like that for allergic rhinitis?
I always start out with the parents is that my training is not, you know, not versed in acupuncture and natural medicine. I'm an allopathic physician. Now that being said, that doesn't mean I discount other treatment options out there. An acupuncture physician is someone who's gone through extensive training, and acupuncture has a very, very long history. Being of Indian origin, this acupuncture therapy actually originated thousands of years ago and has been shown to be helpful in various things. Now, are they large studies? No, but at the same time, if I always encourage parents, if you find someone local and you're finding that their symptoms are working, please share the information as well, who the provider is and what they're doing. So I have an opportunity to learn from what's happening now.
Yeah.
I always qualify that with, but make sure that the treatment is not delaying the care that can result in speech delays and other problems.
Yeah.
And even with like elderberry, echinacea, ginger, and those types of things, those are all things that I think help people feel better. Now, in terms of the science behind it, I definitely have not seen strong science other than I know that ginger is known to be a strong anti-inflammatory and
Mhm.
strong in, immune stimulant as well as in a way a natural blood thinner. So, it is something that I've had some experience with because we use a lot of ginger in cooking, being of Indian origin.
Mhm.
And I've had issues where if a parent is eating a lot of ginger and I'm having to do an office-based procedure, whether it's nosebleeds or tongue tie, they actually do bleed a little bit longer.
Mhm. The issue I find when parents are coming to me regarding some of these alternative herbal or dietary supplement remedies is that the concentrations can vary greatly depending
Mhm.
on the company you're getting them from. And with the little literature we have on them, right, the dosages or concentrations of these things are very specific. And I think
Mhm.
that's another thing I counsel parents about also is one, the all other side effects of them, because they're still giving their child something, even though it's not with a prescription pack, like you alluded to. And then are you giving them really placebo because the concentrations of whatever it is that's supposed to be helpful is so low? And so
Right.
that's where, there needs to be a little bit of counseling because you don't
Sure.
want them to get shammed, if they're not getting something that could be effective if it was given correctly.
Right. And also like all these compounds are products that come from plants.
Hmm.
And, all of us being allergy specialists, I also counsel them that there's always the possibility that your child can be allergic to these products because in they are plant origin.
Sure. Um, Kind of shifting a little to more prescription or more traditional medications. We give a lot of topical steroid to children who have allergic rhinitis.
Mhm.
And there's been a body of literature showing that even with topical steroid, long term, there can be risk for cataracts. And so when parents come in and they hear about topical steroid through the nose, there is some concern regarding long-term use, concern regarding, growth,
Mhm.
etc. Um, what are your thoughts when you're counseling parents? Because again, if you're giving
Yeah.
this to a child and they're going through, being prone to atopy, there is a chance that they're going to be on these medications for quite some time.
Right, right.
So what are your thoughts when you're counseling parents about that?
Well, I start out with the general statement that every action that we have in life has a risk benefit ratio that we either consciously or subconsciously are always taking on. You get in a car to drive into the office to see me. There's no guarantee you're going to make it there, right?
Hmm.
But do you think twice about getting in the car? So in the sense that nasal steroids have been used for an extensively long time and they do have their benefits and obviously they do have side effects. The common side effects I see in my practice is epistaxis. It dries out the nose. I try and counsel them to try and administer it in more laterally instead of medially, trying not to hit the septum. There has always been the theoretical effect on cataracts as well as effect on growth, and there has been case reports on adrenal suppression, but those are all case reports and not necessarily something that you're seeing on a regular basis. And so, I tell them what the medications can benefit with. I don't see allergic rhinitis individually as much as kids coming in with otitis media, chronic sinusitis, hypertrophy of the adenoids, and all of these things are associated with allergic inflammation, which then at that point is like, okay, well, nasal steroids have been shown to help reduce the size of adenoids, which can help with chronic sinusitis, which can help with otitis media, which can help with snoring and sleep problems. And, the alternative is surgery, and even with surgery, there is always the risk of adenoid regrowth. And so as a parent, do you want to jump straight to surgery, or do you want to try something like a nasal steroid, which could theoretically allow us to buy some time, avoid surgery, and then help us go down the allergy pathway to figure out, is there, dust allergies, is there pollen issues, is there a pet issue, is there an allergy that we can try and modify in the environment in the hopes to be able to get you off the medications. And also, there's always the option, once we have the allergy data, to do immunotherapy to try and reduce the use of nasal steroids.
Sure. And a lot of the literature found about the cataracts was it was topical steroid in the eye, through an eye drop. So I don't know how much of that translates, or if, the
Mhm.
risk is significantly higher when it's delivered to the eye as opposed to the nose or lung or whatnot. So that's something I also talk to parents about too. But it is definitely a question that,
Right.
the media has sparked that we really should be aware of.
Oh, absolutely. And the local ophthalmologists are actually very concerned if they have a
Yeah.
parent that has early onset cataracts. They really
Sure.
do counsel the parents, especially with their kids, to not go on nasal steroids. And it's just how hard to counter that. But the alternative is, do you want to go on montelukast, which has
Sure.
its own range of scary side effects?
Sure. Sure. Another thing that I struggle with along with parents, we have some kind of older kids or adolescents in the office where their sleep studies are coming back with very borderline OSA,
Mhm.
and they have very significant allergies that are not treated. A lot of times, parents are asking, do you think we can avoid tonsillectomy, adenoidectomy if we treat the allergic rhinitis? The standard of care is there's OSA, you know, tonsillectomy and adenoidectomy is a standard of care.
That
But
has changed actually now, so that
yeah,
in the American Academy of Pediatric Otolaryngology, the algorithms have changed. Unless if there's significant hypertrophy of tonsils adenoids, 3+, 4+, when it's 2+, borderline hypertrophy with significant allergic findings, the current standards is to try nasal steroids, leukotriene inhibitors, to go down the allergic pathway, because removing mildly enlarged tonsils and adenoids is not going to cure the sleep apnea. It may improve the numbers some, but it's not going to
yeah.
resolve it. And also, like, the literature does support in a child who's not having chronic tonsillitis, adenotonsillar hypertrophy may be of allergic origin.
And what about asthma? So a lot of the parents are asking, my kid is sick all the time
Mhm.
and they have allergies and they have this borderline OSA. Well, which of these treatment options are going to make them get sick less, or is this going to make their asthma better?
Mhm.
And I think
Well,
sometimes they're lumping all the upper respiratory kind of stuff
sure,
going on with the kid and they're
sure.
looking for a cure-all.
Yeah.
And I find myself having to hedge a little in terms of expectations. How do you kind of resolve some of the questions the parents are asking with regards to that?
Well, I present it the way of root cause medicine. So I asked them the question is, you really haven't asked the question, why are the tonsils and adenoids enlarged?
Mhm.
Asthma is known to be an allergic disease. There's very little debate about that. Allergic rhinitis is known to be an allergic disease. It's in the name itself. And, if you look at, why are tonsils and adenoids large? Well, what do they do? They're part of our body's immunologic response, that hypertrophy in response to some foreign antigen coming in, whether it's bacterial, viral, irritants, pollen, pollution, as well as allergens. And so there is reasonable literature, um, case reports, as well as histologic studies to show that allergic inflammation is a potential contributor for adenotonsillar hypertrophy. And so when I'm operating to take tonsils and adenoids out, that is not addressing why they got big. It's just addressing the fact that they were big. And
Mhm.
even in kids with huge tonsils and adenoids, I generally do tell the parents, look, why they're big, the surgery is not going to fix. And you'll be back in a year, 3 years, 5 years to talk about allergic disease at some point
Sure.
in this child. And they end up coming back a few years later. And whether it's to deal with allergic rhinitis, whether it's to deal with
Mhm.
asthma, or eczema, some type of other allergic pathology. Because surgery does not address the reason why you're doing the surgery. It just addresses the disease that you're trying to address.
Sure. It's a structural fix, not a physiologic one.
Or the
I
problems.
Yeah, I tend to get a lot of in vitro allergy testing in the OR,
Mhm,
because I tell them we're taking care of a structural problem, and
mhm,
we need to see if there's a physiologic problem that we're going to need to treat afterwards.
mhm.
And so
Right,
a lot of kids, they might have some light snoring or some residual snoring after TNA,
right,
and it worries the parents. And so sometimes we talk about why that's happening, if it's dangerous to a kid's health and
right,
things like that. And my understanding is if there is some mild residual apnea after TNA, there is a recommendation for Singular to be tried as an option
right,
in some of the newer consensus statements. And so I think that tells you about kind of what a root cause may be for some residual snoring and apnea after TNA.
right. Absolutely. And like I said, I usually have that conversation actually prior to the TNA is like, no surgery done in healthcare is going to be 100% effective, but the indications are definitely present. If we're still having residual symptoms, we'll just have to do a deep dive down the allergy pathway.
Well, thank you. I actually learned a lot, in terms of how to alleviate some of the more challenging questions from worried parents. And I hope we can do this again because there's always questions
Absolutely.
coming in.
Yeah.
I encourage all of our members, if you have challenging questions for Dr. Patel or something that's, you want to discuss, please reach out to the AAOA. We hope to do this more often and kind of give everyone some pro tips. So thank you for joining us, Dr. Patel.
Thank you for having me.
Have a good one.